So without further ado, I'll begin today's webinar, which we are entitling Integrating Palliative Care Responses in Emergency Responses. We have three excellent speakers with us today, and I'm going to go ahead and introduce the first two speakers who are going to give us several talks, and then I'll introduce Dr. Nala as she joins our panel a bit later. So first, we have Dr. Moira Lang, who is a specialist physician in palliative care, and she's worked for over 30 years on 4 continents, including the UK, India, Africa, and the Arab world, with 10 years experience in Gaza, where she seeks to build capacity for integrating palliative care and building evidence about best practice and research capacity. She has a passion for values-based transformation, reaching the most excluded and marginalized populations, particularly those in humanitarian settings. She's a medical director with Cardis International Palliative Care Trust and a senior advisor with the Makerere University Palliative Care Unit in Kampala, and many, many other very senior appointments. So welcome, Dr. Moira, who is also on the executive of PalChase. And our second speaker will be Dr. Ben Thompson, who is a general internal medicine and nephrology physician from the Toronto area in Canada. And he's been involved in humanitarian work since 2013, predominantly in Uganda, as well as in Gaza and the West Bank, and in Indigenous communities in Canada. And he's worked on developing the provincial curriculum for Indigenous communities. He's been to Gaza over a dozen times for clinical work and project development, including in September of 2023 and most recently in March of this year. He completed his medical studies in Ireland and his specializations in Canada. And he's working on his master's in public health, specializing in humanitarian health. And he's delighted to be with us today. So welcome both Dr. Moira and Dr. Ben. And I'm going to hand over to Dr. Moira first, I believe, to give about a 20-minute presentation about integrating palliative care into emergency responses. And then we'll go to Dr. Thompson after that.
So, Megan, really kind introduction. And I think we've got 10 different countries worth of people joining us. So that's exciting. And we look forward to your engagement. Now, Ben and I have both been in Gaza quite recently. And we have been looking at this issue of NCDs and working very closely with Nala. So we're delighted today to come together and give you a feel of what we've been finding out on the ground, what we've been presenting, and to get a discussion going really about where this goes to from here. So I'm going to set the scene by giving an overview and looking a little bit at medicines access and some of the issues relating to palliative care. And then Ben's going to come and add to that, particularly with looking at nephrology, which is such an important area, and we don't often talk about that at these meetings. But I wanted to start by just paying tribute to our colleagues in Gaza. The pictures here you can see on the right are Gaza as it is now, and the top one is the destruction of one of the universities. You'll have seen the pictures on the screen. So as we start, and we're not just looking at Gaza, we're looking at humanitarian settings, but I want just to pay tribute to our colleagues in Gaza, who are operating under the most incredibly difficult circumstances, who are operating with almost no health facilities now, with borderline or actual starvation, with detention, and with the threat of more invasions, and particularly a situation where healthcare has become a target. And these are 3 of our colleagues. The one on the right on my screen, Dr. Hama Malo, was known to Ben and I. In fact, is how we met and started to work together, because he was a very dear colleague who was killed, a nephrologist in Gaza. You can see the head of medicine, Dr. Rafat Lubad, and our dean of the medical school previous team, Omar Farwana, just 3 of our colleagues who have been killed. And I want to just take you with me as if you were coming into Gaza. So when you get to Rafah, the first thing you see is this endless queue of aid trying to get in. Then you see overflowing cemeteries. And of course, this is somewhere where you can build a cemetery. Other places, it's just mass graves. Kids outside the UN building, burnt out shells, people trying to live with dignity, and even on the edge of the sea as they're being pushed that way, and the smell of sewage is overwhelming. Accessing water, I heard today the temperatures are very, very high and people are really struggling. And healthcare, again, you can see here an ambulance under attack. So this is the the context, not just here. We could show pictures from Ukraine, we could show pictures from Yemen, from Afghanistan, and from other places that some of you will know well, but where we're in an acute emergency situation. In Gaza, of course, that acute emergency involves people being trapped, so they're unable to move and therefore can't flee and are having to endure whatever comes their way. And that's a pretty terrifying experience. I'm going to ask you just to, as we watch this 1 minute, just to reflect. And if you're somebody who prays, to pray, just to think about trying to do healthcare in this kind of environment. That was taken with my phone, just leaning out of the car on a street called Saladin Street, which links the north and the south of Gaza. It's hard to watch, and it's unimaginable to be there. So that really is why this first slide has the very first thing, seeing staff support. What we were seeing on the ground, and this is reflected in many settings, is the staff themselves need help. In Gaza, they are displaced 5-6 times. They're looking for places of safety for their family. They have no salaries for 6 months, and yet food prices have escalated to 5, 10, or even more times it was before. And they need us to show genuine solidarity and support for them and genuine partnership. We've talked before at these webinars about the need to address some of these power differentials, that it's not about us going to help them, but actually together coming in partnership in a dignified and respectful way to offer what care we can. And so there needs to be a building of local capacity, wherever that is, and some ownership from local capacity, the leaders and those on the ground. But there is a real crisis across the world, and it's been highlighted in Gaza, and that is in the emergency response. NCDs, which includes the areas we're talking about today, are really not represented. I would actually say almost 99% not represented. And that also then leads into other things like equipment and medicines and how it's needed. So there's a gap. We've done a really good job, I think, of beginning to integrate in the preparation phase and in the response phase, the sort of rebuilding phase, but not in the emergency phase. The other thing that's striking is that multimorbidity is the norm, and then you've got a chronic illness, maybe more than one, and then you've got an acute illness, and then you have an injury. So these vertical streaming and planning is not helpful. There's often little access to imaging and blood tests, blood products, etc., and that's the case here, no histopathology at all. And all medicines are in short supply. And interestingly, then the priorities may change. So it may be that long-acting medicines are much more appropriate, or things that people don't have to come back to health centres so often. So a 3-month prescription. We also saw huge problems with basic things like skin care. And we saw patients dying of sepsis because of the lack of effective ways to protect the skins when there's no electricity for the usual fancy beds. And the need for psychological first aid and care in how you go in as a team to work with people. Let me introduce you to Mohammed. He was a civil engineer by trade and was diagnosed with follicular lymphoma 4 months ago. He's in Al-Najjar Hospital. Now, that's a hospital that was built with 60 beds, small hospital in Rafah, and it now has 700 plus patients every day. He has been referred for 4 months, and interestingly, his sister and his father have both been referred, one with myeloma and one with a flare-up of her really quite serious inflammatory arthritis. So a picture of chronic illness in one family. His disease is now extensive. He has recurrent chylous effusions, but I'm delighted to say that this gentleman actually has good palliative care from Dr. Amjad, who's just standing in behind some of the people that we've trained. If you want to know what's on his t-shirt, it says nothing is stronger than love except for an Apache helicopter with rockets. This young man had a very accepting and very, he was a very courageous gentleman who knew what was happening, was talking to us about it, was hoping for a referral out for treatment, but was also very appreciative of the care that he'd got. This is the small oncology team that is there in Rafah. There's a few others scattered, and that's another challenge. People are scattered, and new cancer diagnoses are very difficult to make. There's a mistake on this, I should say EMRO, but let's zone out a bit from Gaza to look and see what's happening globally with this issue. So the EMRO has been leading the way with this framework document that was launched last year. And also there's been a high-level meeting, high-level technical meeting, very important meeting in Copenhagen recently, and some of us were there representing. And I think there is now really very significant buy-in and acceptance from the international community that this is missing, and that there might even be more deaths from illness, chronic illness, than there are from trauma. Certainly there will be a huge number, particularly when you add in infectious diseases such as cholera and the other outbreaks we see in emergency settings. Hepatitis is very common as pneumonia, and this is repeated against all through all emergency settings. I mentioned the 3 phases. I think we have done relatively well to integrate in the preparation and recovery stage, but not in the emergency response stage. And that's why that's the topic of today. But a lot of the things that happen in the response stage only can happen if the preparation stage is done well. I'll mention some of those in a moment. Palliative care is particularly challenging because it cuts across all of them, and they have some particularly difficult issues around medicines access, although I'm sure Ben will share challenges in other areas in medicines access as well. When we look at what we need to do, well, we've got our palliative care house. We're used to this. It's the same overall picture, but then applying it into a situation where the health system may be completely destroyed, or it may be only deliverable in field hospital settings, or it's a displaced population. So I just look at access to medicines for a moment. The policy issues here are even more complicated because you may have to pass through another country to get your medications. So there may be 3 layers of policy: importing to one country, exporting from that country, importing into the country that's experiencing the emergency. My understanding is in recent days, it's only been successful in Ukraine and South Sudan because there were some systems in place beforehand, or the governments were still functional. But that doesn't mean we shouldn't try. So get our policies done as well as we can before an emergency, and remember fragile states and focus on that. The procurement, as I said, is very complicated. I will show you on the next slide a system of kits that are there for WHO, and there sometimes are one-off supplies. For example, the day I was there in Gaza, they had got supplies via UNICEF, and they were delivered to that small clinic where we had capacity from trained colleagues. Standard protocols really helpful, because in an emergency setting when all sorts of people are coming in, having agreed protocols is helpful. And I'll show you the ones that we re-released in Gaza. Here they are. Now, in fact, we had worked on these already. So all we did was change 1 or 2 lines. These owned by Gaza, which I think is really important, and they clearly put the pharmacist in a significant role. Rather than a few fentanyl patches arriving here and an unknown opiate arriving here, we wrote it very simply so that then the pharmacist could advise what's there in the stores. And one of the sad things in Gaza and other places is the stores get regularly destroyed as displacement happens. So with this rapidly moving population and the destruction of the health system, it means that even the stores that are there get destroyed. The kits is complicated and it affects the whole of NCDs. There is an NCD kit. This has been an amazing step forward by WHO. It's meant to be for 10,000 people, mostly in a primary care setting, like getting into a rural setting in where there's been an earthquake or a displaced population. It doesn't have controlled medicines, but there are 3 other kits with controlled medicines. That's the CR module. The challenge I've mentioned is getting those modules in. So in this circumstance, most of the medicines get in through the normal channel, and then the controlled module can be separately managed for procurement, and you can order more than one. But when we've been looking into this and working hard with Nahala and others, for opiates, there's only really enough for 1 or 2 patients per month, and yet it's for 10,000 people. So there's a lot of work to be done to look at the content of these kits, but there is some precedent there that we can work on. Mass casualty events. Internal medicine, palliative care, we need also to be aware of what's happening in the mass casualty. We've seen this slide before from Nepal, showing an old-fashioned way of mass casualty events. But I'm delighted to show you this today. This is from the WHO Academy. It's a really helpful way of looking at mass casualty, where the blue zone, which is where most of the patients with multimorbidity and those with who are not going to survive because of the extent of their injury or the lack of access to treatment, are managed together alongside, but in a separate zone from the yellow and the red, the more active zones. This is vital for several reasons. It means they're active care, which is hugely important. It also means that if the situation changes or the condition changes, they can move. It also means that if you have, for example, a new line to get an IV or whatever, it's much more available. And this is a lot more dignity. But how do we train people against this? This is a great training module, but I would say need to be more involved with our colleagues. This is in the emergency unit. I think this is an excellent design, and it'd be great to see more cross NCD and palliative care training embedded in all first responders, because I think we need an awareness, particularly amongst our emergency colleagues. We did identify at some of these issues at our high-level meeting. My apologies, apologies. So I think I've said some of these things, integrated into the emergency response, including the content of emergency medical teams, mass casualty triage, medication supplies, and holistic support for patients and families, but also for staff. Review the emergency kits and look and see if we can get the right amounts in the right place with the right protocols. And in the phase 1, that means the preparedness phase, let's look and see if we can do more training. I also want to mention something in passing, and that is the health and peace initiatives from WHO. I think there's things we need to think about how we might contribute to those initiatives, and maybe that's a topic for a future event. I want to come back to our colleagues and the courage of our colleagues. This is from one of our pharmacists. Despite the pain, hope persists. How there can be hope in such circumstances is a tribute, I think, to the faith and humanity of our colleagues on the ground in their emergency settings, carrying on caring for patients, even when the situation is almost unbelievable. And then I want to, just before I finish my comments just now, there'll be time for questions. I want to just read a letter from a 6-year-old, because this is affecting all ages. And this 6-year-old is the grandson of a colleague of mine from Achley Hospital. And he wanted to write me a letter, and I'll read it to you. Hello, Dr. Mohira. That's my Arabic name. I'm from Gaza. I had a life. I had a home. I had toys and everything. I was happy. Now I don't have friends because Israel killed them. My hope is burned when we were there. I can't sleep since this day, and every day I dream of fire and bomb. I want to live in peace and happiness. I want to play and go to school. I'm so sorry to say this to you and make you sad. I'm happy that you're here to help people. I hope next time everything will be okay when I see you, and this sticker is a gift from me to you. I love you. In this little excerpt is humanity, is the reality of the suffering, is the hope of a little child, and is his concern for me, that dignity. And these stickers, Gaza's famous for its asir farawla, for its strawberry juice at this time of year. So let's hold on to that humanity. And I want to read just a meditation that is written. This is a reply meditation between a professor of English in the UK, a professor of English in Gaza. They've been working together for many years, and they write these joint prayers. So let me just read this meditation, then we'll finish. Sud is the courage and steadfastness, a term that means a lot in Arabic and means a lot to Palestinians. Bless the helplessness, the utter helplessness, the unutterable agony of utter helplessness. Bless the endlessness of the helplessness that still resists death daily, even as the helpless are dying for want of help. And the reply from Gaza, bless the help that never ends and the endlessness of our friends. Bless those who defy despair by planting hope and the despair that ends with a strong rope. Bless those who pray for the end of war and those who keep trying to open for us the door. Those who keep praying for our kids and those who keep trying to make us well fed. Thank you, and I'll hand over to Ben.
Thank you so much. I'm just going to set it up here. Okay, can you give me a thumbs up just that you can hear me okay? Okay, excellent. Thank you so much. Well, thank you so much for the opportunity to speak with you today. You know, as a physician who spends the majority of his clinical time managing people with kidney disease, I'm excited to talk about this topic, but also because it addresses my other passion, which is addressing healthcare during humanitarian emergencies. So I want to start by introducing you to a man I met in Gaza in March of this year in one of the dialysis units, one of only 2 dialysis units that's still functioning in Najah Hospital in Rafah in southern Gaza. Now, Ahmed wasn't originally from southern Gaza. He was from northern Gaza initially. And in September 2023, he was going to this facility, the Indonesian hospital in northern Gaza, 3 times a week for his dialysis treatments. These treatments kept him alive. And although he sometimes suffered cramping in his legs during the treatments, he was otherwise tolerating his treatments very well and was able to continue his work as an engineer and to support his wife and children. However, in November of 2023, this hospital was destroyed after an Israeli raid, and the dialysis unit was no longer accessible or usable. Recognizing that he would die without his dialysis treatments, Ahmed and his family migrated south to Gaza City, where he hoped to undergo his dialysis treatments at Shifa Hospital. Unfortunately, when he reached Shifa Hospital, much of the building had been destroyed. The dialysis unit had suffered a fire, and only 5 dialysis machines were still functioning. Water and electricity were not reliable, so the dialysis unit ultimately shut down, and Ahmed quickly had to find another facility to get his life-saving treatments. So he and his family moved here to Deir al-Bala to access the Al-Aqsa Hospital dialysis unit. Now, in September of 2023, there were 5 outpatient facilities for people in Gaza to receive their dialysis treatments. But by the end of November, the 2 largest facilities had been destroyed, leaving only 3 facilities for over 1,100 patients. This meant that dialysis treatments were rationed. In September, Ahmed received 12 hours of dialysis per week, split into 3 treatments of 4 hours. By late November, he was receiving only 2 treatments of 3 hours per week, basically half of what he needed. And this reduction in dialysis increases mortality, but also significantly increases suffering. By January of 2024, he was regularly suffering from nosebleeds, severe pruritus, nausea every morning, limited appetite, All of these are symptoms of having insufficient amount of dialysis. He knew he was slowly dying, but he was still desperate to receive as much dialysis as was available, again, for him to survive. Now, Dr. Lang spoke of the shortages in medications and the wonders of the NCD kits, but certainly, we did hear about the limitation in opiates. There's also significantly limited access to medications to treat non-communicable diseases that are very common in this patient population, such as hypertension, diabetes, and chronic kidney disease issues related to bone disease. Those medications are essentially non-existent. So back to Ahmed, unfortunately, in January and February of 2024, Israeli military incursions into the Al-Aqsa hospital with arrest of many of the physicians forced that dialysis unit to close. It ultimately did reopen later in February, but it was temporarily closed. And patients who were receiving their dialysis treatments there, again, like Ahmed, desperate to survive, he and his family migrated again, this time to Najah Hospital in Rafah. And this is where I met him. So this is a picture of Najah Hospital in southern Gaza from 2020. And what you're seeing is people in front, locals from Rafah, and they're out front with signs complaining that the hospital is too small for Rafah. This was 2020. So you can imagine in 2024, if the hospital was too small in 2020, it's definitely too small in 2024, where there's now about 1.5 million people. 70% of the population of Gaza has been forced to migrate south, and the majority, of course, resides in Rafah. Now, when Ahmed arrived here in February of this year, there were 615 patients receiving their dialysis treatments there, even though the dialysis unit in September of 2023 managed only 115. So more than 5 times their initial capacity. And since there were more than 5 times the number of patients, the dialysis unit had to cut corners. Firstly, the dialysis unit never closed. Typically, dialysis units close for about 6 to 8 hours a day so that the water system and machines can be thoroughly cleaned. By running the unit continuously, this dramatically increases the risk of bloodborne infections, including hepatitis B, hepatitis C, and bacterial infections. The second issue is that the amount of dialysis provided to each patient was also dramatically reduced. Consider that Ahmed was receiving 12 hours a week in September 2023. Now he's receiving 2 treatments a week of 2 hours each. So approximately a third of what he was receiving previously. Now, at this time, Ahmed was getting daily nosebleeds. He couldn't sleep at all because he had diffuse and severe pruritus. He was up scratching all night, every night. He was accumulating fluid everywhere. He had severe fatigue, no appetite, and he was waking up again every morning feeling nauseous. He wasn't getting anywhere near enough dialysis, but he was lucky to be getting as much as he was receiving. And he would say to me, "I'm lucky to be alive." And one can think about that emotionally, but I think about it academically. Was he actually lucky to be alive? Or, placing it as a scientific question, was it improbable for him to still be alive? What was the probability of his mortality within a year? And so we've established from a fairly wide range of studies that the 1-year mortality for hemodialysis patients is about 7 to 22% in high-income countries, and in low and middle-income countries is about 20 to 35%. How does this compare with other conditions? And how does this change in a humanitarian emergency? Well, we've already established that even outside humanitarian emergencies, someone who was on dialysis, here represented by the abbreviation HD, and we should be looking at the red bars in the middle of the chart, there's a 5-year survival that is lower than stage 4 Hodgkin's lymphoma. If you're over the age of 55 and on dialysis, your 5-year survival is about as good as stage 4 cervical cancer. and worse than metastatic prostate cancer. Needless to say, outside of humanitarian emergencies, the 5-year survival for someone on dialysis is worse than many conditions we very commonly associate with needing early palliative care. Now, within humanitarian emergencies, there isn't good data available on mortality rates of hemodialysis patients. However, I was able to secure some relevant data to extrapolate a 1-year mortality. Now, this data is imperfect. It's really my best guess. This isn't an official way to do it by any stretch of the imagination. You can sort of think of this as a scribble on the back of a napkin approach. So far from official, but it's the best that we've got. We know how many people were on dialysis in Gaza October 1st, how many were on dialysis March 15th, and we know how many people left Gaza. We also know that patients with end-stage kidney disease who are dependent on dialysis usually die within 2 weeks if that dialysis is stopped. So using that data alone, the mortality rate in 5 months is 26.4%, which extrapolates to an annual mortality rate of over 60%, which would be higher than any previously published mortality rate in any dialysis unit anywhere. So even if these numbers are off by a bit, we can certainly say that the mortality rate in a humanitarian emergency of this population is dramatically increased. Now, of course, we're not interested in just the risk of death here. We're also interested in quality of life reductions and suffering. And these are two figures that you're likely already familiar with. In a study in the late 1990s in the United States, over 3,700 nursing home residents were followed for functional status and quality of life as measured by the MDS-ADL scale, both before and after starting dialysis. Certainly, this cohort is older than the average or median dialysis patient in North America or even in Gaza. However, this study did provide us with fairly useful information for those of us who practice palliative care medicine. Let's look first at the figure on the left. So what we see here is that functional status was maintained in only 10% of these patients by 1 year. 75% of these patients had died, and the rest suffered significant decline in functional status. Let's go then to the figure on the right. And I think this figure in some ways is more important because it shows that even before dialysis starts, so in our patients who have chronic kidney disease not on dialysis, as they approach dialysis, they are already suffering significant declines in their functional status. This decline in their functional status is equivalent regardless of patient sex, patient race, and patient cognitive status, including if they had documented dementia. This process was still the same. So basically, this is a risk factor for everybody. So let's go back to Ahmed and ask ourselves, well, what symptoms are actually important to impair quality of life? Well, these are roughly the prevalence of symptoms on people who are doing chronic dialysis therapy. And consider these numbers are based on North American units, like dialysis units. So these are patients getting 3 times a week, 4 hours. So outside of humanitarian emergencies where that frequency is often much less. So if you think about it, the most common side effect is severe fatigue. And that symptom tends to get worse the longer one's been on dialysis. And that unfortunately is not something we have good treatments for. However, on this list, there are symptoms that we have good treatments for. For example, the most distressing symptom is pruritus, nausea, vomiting, headaches, restless legs, cramping. These are all symptoms that we actually have treatments for, and both outside and inside humanitarian emergencies that we can focus on to improve the suffering that patients are going through. So then, how do humanitarian emergencies modify our palliative care response, specifically as it relates for patients with kidney disease or patients who have chronic kidney disease? Well, I think the first thing to mention is that displacement which is essentially ubiquitous in humanitarian emergencies, places a massive amount of pressure on local kidney programs, not just dialysis programs, but it reduces the capacity for care for people who are on dialysis, as well as people with chronic kidney disease not on dialysis. That displacement is not just displacing them from their regular medical care, it also displaces them from their families and from their support networks, which are severely disrupted and also impairs their or escalates their suffering. We talked about access to medication being a huge problem, but often in the case of an emergency, patients are displaced from their medication supply at home, and often are displaced as far as their access to medications wherever they end up. Ahmed and his family are currently living in a tent with very limited access to any form of healthcare. And so very, very difficult for him to get access to very basic medications even. The other challenge in a humanitarian emergency that we saw looking at kidney transplant patients, and this happens in other areas of non-communicable diseases as well, is that when patients have limited access to some of their medications, but reasonably good access to a limited subset of their medications, is oftentimes they will get massive doses of one of those alternative medications. And transplant is a good example of this. So I saw, for example, a young man in his 20s who had developed Cushing's secondary to very elevated doses of prednisone that he was exposed to for several months at a time, simply because the alternative immunosuppressants were unavailable. And that sort of suffering also we witness. Patients with non-communicable diseases as well, we have to consider, yes, they do suffer from the non-communicable diseases, but it also makes them more vulnerable to the impact of trauma and communicable diseases and infectious diseases. Within the healthcare system, the emergency medical teams in a humanitarian emergency, and even the health resources locally, are often focused specifically on traumatic injuries. So there's limited capacity to focus on things like palliative care, kidney disease, hypertension, diabetes. And that's something that is changing. Dr. Lang did mention specifically that the WHO role in enhancing NCD response in the response phase of a humanitarian emergency is changing, and it's something that we are seeing as given slowly is being given a little bit more priority. And then, of course, that again, mentioning the lack of prioritization of NCDs. So I want to go back and finish specifically on Ahmed and what is our role with him? Where can we intervene and enhance his care? Well, I think, I go back and I ask, well, what is our role as nephrologists, right, in palliative care, just in general? And I think, we've been very, very slow as nephrology field to heed the advice that's shown here. So, we started in 1991 recognizing that, as nephrologists, we've always focused on increasing survival with very little attention on quality of life. And that opportunity to integrate palliative care really was focused very limited. And in 1991, even though this was stated, we really were slow to heed this advice. And most of the work in palliative care within nephrology focused specifically on end-of-life care. That being said, of particular importance, in 2000, there was a multidisciplinary meeting with palliative care physicians and nephrologists that really was probably one of the first times precipitating further discussion, meaningful discussion on what is the role of palliative care. Unfortunately, at that time, the recommendations from that meeting still focused specifically on withdrawal from dialysis, and there was still very limited focus on symptoms. That really only came about in 2004. And that was a meeting specifically about how to expand past this problem of looking at palliative care just as end-of-life care withdrawal of dialysis. And that 2004, I think, was a really important time point because it precipitated a lot more discussion, a lot more research specifically on palliative care and nephrology. And now there actually is a palliative care nephrology fellowship that one can do that's come about in the last 5 to 10 years across Canada and the United States that I think really has changed that impression of being something just about limited to withdrawal of dialysis. And in 2008, I thought these guidelines were specifically pretty helpful because it looked at the total active care of a patient and family, including pain and symptom management, psychological, spiritual, and cultural care. And that was really a moment of really importance, taking it outside of just withdrawing dialysis, looking at bereavement, support to professionals and family cares. That was a really important moment, I thought, and precipitated a lot of growth in that field. And so when I think about, okay, well, what can we do here? What can we do in a humanitarian emergency? Well, I think the first thing is linking family and carers and patients to other healthcare providers that can think about social, cultural, and psychological aspects of well-being. Looking at symptoms, pruritus, dyspnea, chronic pain, nausea, these are very common symptoms, specifically in people with kidney disease and on dialysis, focusing on symptomatic management there. Also, especially in people in humanitarian emergencies who have been exposed to multiple forms of trauma, not just in form of displacement, but also there's multiple other forms of trauma, be it gender-based violence, be it loss of family members, either due to displacement or loss of life. A trauma-informed approach to care needs to be provided. I think as healthcare providers, we also need to be very strong advocates, not just for non-communicable diseases. Oh, Megan?
Hi, Dr. Ben. Just if you could wrap up within about 1 or 2 minutes, please.
I will. Yep, this is my last slide. Yep, absolutely. Yeah. So, as advocates, specifically for making sure palliative care is a focus in research, as well as in data management with the ongoing emergency plan, medical education of people who are working in nephrology with regards to palliative care. And then, of course, there are the issues about withdrawal of dialysis, bereavement, and end-of-life care. So looking at Ahmed, I think, all of these issues can certainly be directed towards him. Pruritus, nausea, those symptoms can be managed, providing mental health supports for he and his family, advocate for the national system in Gaza, as well as at Naja Hospital, to have data management and care pathways for palliative care. Consider bereavement programs for not just his family, but other families. And opening up the discussion, does Ahmed want to consider withdrawal of dialysis? And is there a plan in place for that? Can we talk to him about the consequences of that? So I'm sorry, I think I have gone over time. I'll end my talk there. Thanks so much.
Thank you, Dr. Bennett. And sorry to have to ask you to wrap up a little more quickly. I know you have really valuable insights to share. And so now I'm going to just introduce Dr. Nala Gaffer, who's going to join both Dr. Ben and Dr. Moira on a panel for some discussion for the next few minutes. So Dr. Nala Gaffer is a clinical oncologist and specialist in breast cancer. She was working at Khartoum Oncology Hospital. She then trained in palliative care, starting in 2009 and 2010, and opened one of the first palliative care programs in Sudan, growing to provide an extensive palliative care service within that hospital. And she has then, since that time, been really working on contributing to activities in palliative care throughout the region, working with Cardis, going to Mauritania, working with Gaza Islamic University online. And I know that she's currently completing her PhD research concerning the early integration of palliative care into oncology from King's College London. And last year, Dr. Nala was displaced from Khartoum to Cairo with the breakout of the war in Sudan. And she's the mother of 2 young men who are with her there as well. So I welcome Dr. Moira, Dr. Nala, and Dr. Ben to the panel. And I'll ask Dr. Nala to first give a few thoughts. And I wonder if we've heard from Dr. Ben a little bit about how chronic kidney disease is being managed or integrated, and the thoughts about palliative care in humanitarian settings and emergencies. but I know your expertise is in oncology, and if you want to share some thoughts about bringing that integration of the oncology perspectives and care for those patients in the emergency phase of a response.
Thank you so much, Megan. Wonderful to be with all of you today. I'd like to speak a little bit about the suffering of cancer patients. And I think Dr. Thompson and Dr. Link has clarified that in humanitarian situations, palliative care is needed to embrace all. It shows us that we need palliative care even more, not only for dying, but also for the people who are living. Okay, and I'll just share some of the situations that is happening in Sudan. A lot of cancer patients, because of lack of medication and a destroyed infrastructure, a lot of recurrences are happening, progression of their disease is happening. And even the patients who are receiving chemotherapy, my colleagues who are still in Sudan are reporting that the patients are experiencing more side effects, and they are seeing more deaths from side effects. And that is the accumulation, I think, also, as you mentioned, reduced nutrition and this lack of family support and lack of situation where you don't have a house and you are running around and you don't know what is happening and what to do. So the importance of palliative care is increasing more and more in humanitarian settings for people with non-communicable diseases. And one of the things is linking them and guiding them where to go. And that happened in Sudan, in the palliative care team, where they were connecting with the patients by telephone and telling them where to go and what to do. And strangely, we even have newly diagnosed patients reaching to the palliative care unit because they are the people who are helping out. I would like to mention the problems also for children, especially children in Gaza. The very young, I have seen it with my eyes, some displaced families I met here in Cairo. So the very young children become, what do you call it, stunted, or they lose their milestones. They don't speak in time, they don't walk in time. The more elder children are affected so much. And you can imagine people, and I think Mohaira, you have seen it, Dr. Ben also, if you cannot sleep because of the noise of the bombing day and night. And the mother of the children, she told me that for the last 6 months, she had to keep them at home because it was very dangerous for them to go out. So imagine children trapped at home for 6 months, no school, no activity, no TV, and bombing day and night. So that's very huge. And I think the psychological support that the palliative care people provide should extend to other health professionals, and we need to encourage more people. WHO is doing a wonderful work also with the help of Dr. Mayra and Dr. Ben. And there is this integration of, we are having this emergency and NCD's departments to come up and help, especially with the provision of oral morphine inside Gaza. And for medications also, in addition to morphine, especially for cancer patients, we also, Dr. Mayra has mentioned it, it's very important to think about medications that can last for longer period, 3 months injection, and even the tablets, which are easy to transfer for breast cancer patients who respond to hormonal treatment. It's better than having no chemotherapy. It's better to have some hormonal treatment. I have a quick question for both of you, Dr. Mayra and Dr. Ben, is about when you have when you went there and you met the people you already knew, what was the effect of them seeing you in person?
Do you want to try that one, Mira?
You go first.
You know, Gaza is a funny place because it's so difficult to get in and to get out. There's often lawyers involved, appeals if your application to get in is rejected. There's almost an expectation of people who live in Gaza that you're not coming back. that's almost the expectation. So I've been there over a dozen times, and every single time I go and I show my face there, it's like I've never been there before. They're like, "Oh, you're here. Oh, wow." They're like shocked. I can tell them I'm coming. I can tell them the date I'm crossing. It's still shocking to them that people come. And um, you know, certainly when I came this time, there's quite a lot of interest, and you know, there are a lot of groups going in now that are predominantly surgical, and organizations that are going to European Gaza Hospital. And I think most of the people who are going in now with the emergency medical teams, it's their first time going. Many of them won't come back. They're there for the mission, and they'll do their surgical mission and not come back. But I think the overwhelming majority of people that I saw when I was there, that I knew from before, like every other time, were shocked that I was there. You know, as if why would you come here? Why wouldn't you, just, or just, it's so difficult they don't expect you to come back. I don't know if you had the same experience.
Yeah, a little, although I think both of us have the privilege of teaching in university. So I know kind of half the medical students and the interns. And actually, it was really moving to wander through the hospitals because we were visiting and seeing patients and had people just coming up. And just one person said to me as I walked in, imagine there's somebody in the whole of this world that still cares about us. Now, that's not me and Ben. That's all of you who would love to be there, but can't. And another person, I think it showed their humanity. They talked about, the sense of non-abandonment. That's something we know about, Rick, about in terms of spiritual care. So the sense that being there was a sense of solidarity and presence, and that just by being together, we were, one of them described it as a sanctuary of compassion, which is really a beautiful term. So I think that's something we talk about in palliative care, isn't it? That being space. And I know that one comes from Gaza with a great deal of shame, I think, at what's happening, and also helplessness, but there's also a deep humanity and dignity of the Gazans, even in their exhaustion, that they share with us, and we can meet them at that point of humanity as well, and that's an incredible privilege.
Yeah, you make a really good point. I mean, as people who do humanitarian work, we have to be cautious about where is the line between doing humanitarian work versus doing advocacy. And certainly in a place as politically hot as Gaza is, that's something that historically, people doing humanitarian work there have struggled with. That being said, I think physically being there to do humanitarian work is a form of advocacy right now. Even just showing up and doing work is advocacy. Even if you're not doing any other form of advocacy and that's it, people there are moved by your presence, just moved by your willingness to be there and to do work.
Megan, I noticed there was a question earlier from Stephen. Should I pick that one up?
Yeah, please go ahead, Moira. The question relates to how is the triage done in a mass casualty event, referencing that figure that you showed with the blue and the red groups.
I mean, what I found really encouraging, Stephen, and to everybody else, is that the WHO Academy people, the person who was helping design this, had worked for MSF for years, emergency medicine doctor, a New Zealand person, and she sort of really understood the importance of this. The training is for frontline workers, it's not for specialists at all, but it's an awareness of this. So I think the onus is on us to think about how we train people around this. But I think it's the triage that happens, which normally would happen, and you wouldn't come into the recovery room. That's the old-fashioned way. So if you're not got a chance of recovery, you don't even come in. And then the distress for families and the people coming in and saying, please come and see my relative. So they come in and they're managed side by side, so that because it's not a hard and fast thing, that there is a way in which you can move. So why the multimorbidity is maybe the most straightforward one, people who already have advanced chronic illness and are dying, either a result of the injury or just caught up in it. But there's others for whom the injury is too severe, or there is no anesthetic, or there's no blood, or something that might change. So I think it is quite a dynamic triage. But the brilliant thing about this is it's in with alongside other triage. So there is room to change or intervene. And there's also room to think about dignity in dying, which is important for patients and their relatives. It's also really important for staff. I just heard yesterday from an anaesthetist there who I know, who is just, he just said, we need your help because our surgical patients are dying. We're seeing cancer patients in the middle of acute mass casualty, and there's just not the means to properly manage that. So I would love to see alongside this some WHO Academy level psychological first aid training, and also some understanding of how we might support these people, including protocols and plans. Yeah.
The question was more around, because it's great to see palliative care show up in the mapping of this process, but what did they mean? What are the criteria for medical futility? I'm just curious.
It's a diagnosis on the spot, Stephen. So it really is in the opinion of those doing the triage, and this is basic level triage for whoever's there. So it's basically saying they have to do this. They have to put it into yellow, red, and blue, but those categories can have some fluidity if they're beside each other. That's the point. So they have to make their bed. This is mass casualty. It's not a planned considered triage. It's a mass casualty triage.
Really
in a planned considered triage, there'll be more categories. In this one, it has to be on the basis of the person assessing them. But the big difference here is that they're not in that category forever. They might well be rightly in that category, or it might well be that something changes, or they stabilize, or something happens. So it's the opinion of the person who's responsible for that triage event, or the people responsible for that triage event. Yeah.
Thanks.
And it strikes me that having them in that same area allows you to do intensive symptom management for those patients. Have the access to kind of all the supplies and equipment that you need.
Absolutely, yeah.
And I think the framework is so critical. I mean, I can give an example of a case I saw in Al-Aqsa Hospital where clearly this had not been instituted, and yet such an opportunity to use it. So I was in Al-Aqsa Hospital emergency room when I was there in March, and there was a mass casualty event as a result of the massive number of internally displaced people living in hospital, as well as the overflow of patients into the hospital, where the hospital was, multiple 4 or 5 times over the capacity. There simply wasn't the physical space to provide a unified, organized response to a mass casualty event in the emergency room. So we were putting chest tubes in on patients while they were on the floor. We were trying to get IVs in 5 feet away from a family living under a tarp. This was the reality on the ground. Now, one case comes in mind, which was particularly distressing, not just for family members knowing that this happened, but also for all the healthcare staff that were involved. It was a young man, probably late teens, who had been in a house explosion. His right ear and part of his skull had been basically blown off. His injuries were not survivable. He was still brought to the emergency room, and he was laid on the floor. And that's how he presented to us. Now, you can imagine, he was still suffering. There's no doubt about it. He was still suffering. What we were able to offer him was moving him to a room that had a curtain that could be placed on one side of him with the wall on the other side. We had no analgesics. We had no physical space for his family to visit or spend time with him. We had nothing. That was the most dignified that we could offer. And he essentially died in the corner of a room in his own blood and brain matter on the floor. That was as good as we could do, because we had no access to anything. Now, you can imagine if we were able to have triaged him and said, yeah, we're going to identify, this is something that, as awful as it was for us to witness, that happens every day. That is not an irregular occurrence. That can be planned for. there can be physical space designated for him. Those internally displaced families can be moved to a place so that we can identify, yeah, this is going to be the place where we can offer dignified response. We can focus on making sure there's analgesics. We can make sure that there are family supports in place and that there's bereavement counseling for people set up in this location. But there just simply isn't that at this point, there just simply isn't the capacity or the prioritization to make that in any way something that's being done.
Thank you, Ben. I think that's quite a somber note for us to reflect on. And I just wonder if anyone has any, we have about 5 more minutes. If anyone has questions or comments, please just raise your hand. Or if you aren't able, you can type it in the chat. And we did just put the link to the WHO Academy in the chat, which is, there's an online course on mass casualty management. That is where that slide comes from. See a question.
Yeah, sorry, carry on.
Just talking about the dimensions of palliative care beyond health systems, community, caretakers, and relatives. So this is a really good question, and I'm glad somebody's brought this up. Javier has brought this up.
Thanks, Javier. Yeah, it's an important issue. When we were at the high level meeting in Copenhagen, I was really pleased that a whole stream of thinking was around the community support. In the hyper emergency, it's a kind of whoever can access where, which is why we were saying we need to get that. We were working very closely with primary care, both Ben and I, and also with what's are now called medical points. So those are simple health posts really, and mobile vehicles. But because this is a very mobile population, it's not stable. So the communities are just continually changing as the people are moved on this tiny strip of land. But absolutely, this is vital. I was seeing these conversations happening, as Ben has described, in the middle of crazy acute settings. So one of the things we were talking about was how to offer, for example, safe spaces for psychological support using some of these medical points. They're doing some nice initiatives, for example, for breastfeeding women to have a place where they can get some additional nutrition and some privacy. And I think we need to look at how that can also be extended to people who are struggling with palliative care problems, and how we see that as cross-cutting. Somebody told me the whole of Gaza is a hospice at one time. What he meant was there's just such what's called slow death and fast death happening. You just choose between the two. And I think you're right, we need to try and support. There were some psychological support sessions being run for relatives by the teams that were still there, but there's no coordination to that. So we're hoping that that improves. There's also another organization that was previously helping patients at home that I spoke with, and they're hoping to offer more mobile services. A lot of these things can't happen until there's a ceasefire. Yeah, and it's safe to travel. But very good point. Thank you, Javier.
Any comments, I wonder, Nala, from your experiences, and also Ben, maybe outside of the experience of Gaza, from Uganda or elsewhere?
I just want to thank Dr. Moira and Dr. Ben for their courage and their forwardness to undertake such endeavors, to go inside and to support. I was trying to stop Moira by taking away her passport, but I was convinced at the end that she should go, and it really shows you're a jewel. You're both of you are jewels. And I think being there, present in person, adds to the resilience of the people there. They are very strong, but having you reach them makes them stronger. Thank you.
Any comments from you, Ben, about that item particularly, in terms of just like beyond just the health system level? community, the relatives?
I think Dr. Lang covered it pretty well, actually. Yeah.
And Javier's saying that we had the experience with Indigenous nurses providing care after flooding in Venezuela.
Yeah, yeah. I think there's some commonalities with every emergency setting. There's some particularly awful set of circumstances in Gaza because of the trapped population, and that the bombing has gone for 6 months, and now there's mass starvation. But I think there are commonalities. What we sometimes find is that chronic disease might wait a week or two. As you know, as an earthquake or a flood happens. I know in India there was an amazing community response to the floods. It was much faster than any of the governmental responses or even humanitarian organizations, with fishermen picking up boats and taking them inland. So yeah, absolutely. What we're seeing more in Gaza is people digging with their hands to find people under buildings, and you know, it's really quite and to try and record what's happening, because there's no external people there. But I think the message I would say very clearly is we've got a lot of work on preparedness, and we've presented quite a lot of work on what happens a bit later and how we can engage and how we can make sure there's a community ground up approach and how we can do the research around that. But let's see if we can do a bit more focusing on the hyper emergency areas, and where is it that we need to really speak to our emergency colleagues. And I know that we're bringing those two groups together. Thank you for that, because it seems more than ever. I spoke to the head of emergencies, the WHO, Michael Ryan, about this whole issue, and he was saying this is a typical high income view of what's needed in an emergency. Lots and lots of surgeons, where actually what we are seeing is you need a wide variety of things, and it needs to be community and locally owned if at all possible. And it certainly needs to be in partnership with that, and it needs to be contextualized. So I think these are great questions, everyone.
Yeah, and the one thing relevant to Gaza here is that while the healthcare system and healthcare workers have been targeted with over now 400 healthcare workers killed, there's actually quite a lot of underemployment or underutilization of the remaining healthcare providers, simply because many of them have not had, don't have anywhere to work, because all the healthcare facilities have been destroyed. So many of them, the idea of engaging the local health force to develop a program for non-communicable diseases and specifically palliative care, there's a lot of people who are willing and wanting to be working and doing that. So I don't think lack of human resource capacity is an issue here at all.
I see Rick has raised his hand. A few people have raised their hands. I'll call on you. Rick first.
This is for Dr. Thompson. I teach medical students, and I was captivated by that data of how, you're looking more at the quality of life with people on dialysis. How do you teach your students moving from that, I was trained to fix them, to a quality of life?
It's a question I wish I had an intelligent answer to, and I think it's a problem within nephrology historically that when I went through, I finished my nephrology fellowship in 2012, so we're now talking over a decade ago. But even still, I'm shocked at the fact that most of the people finishing their fellowship as nephrologists are not getting any teaching, any of the academic half days, any education on palliative nephrology. And their idea of palliative nephrology, at least locally, still remains like, oh yeah, I'll talk to them about ending dialysis. And that's it, right? So I think it is still an uphill battle. It's still something that we have to be very deliberate about, and saying, well, what are you doing about their pruritus? What are you doing about their chronic dyspnea? What are you doing about their chronic pain? And integrating that within the discussion. And oftentimes, we could talk for hours about the reason why that bias happens. I think as nephrologists, we've become more and more and more specialized. There was a time when I finished that we were generalists, right? We were, we talked to them about their foot ulcers. We managed their diabetes. We were their hypertension doctor. But now a lot of these patients, at least in North America, have 4 or 5 specialists, and the nephrologists are frightened to modify their insulin regimen because, oh, they're seeing their endocrinologist in 2 months and they'll deal with it, right? There's a lot of that in our practice that unfortunately, has made us resistant to have some of those discussions, I think. So if anyone has any good ideas on how to do that, I'd love to hear them, because it feels oftentimes that I'm having these discussions for the first time.
And I think then you have excellent palliative care skills, and we have some joint research around. We have colleagues like in Uganda who are trained in both, so that's something that's changing and developing. Rick, what I was seeing in the emergency setting is all of those sensations of struggling with these conversations and that inner feeling of helplessness. That's why I shared that meditation, are just magnified, because people are coming in for 2 weeks to save people. And I think this conversation is, even hyper acute, needs to happen in this setting prior to it, about how we approach that, and also how we support our colleagues in emergency teams on the ground. One colleague said to me, when he had seen my international colleagues get very, very enthusiastic about saving all the babies, he quietly said to me, "Do you not think I'm broken? Not think I'm not broken at how little I can do for these babies?" So there's some real, I think, areas for people like you, Rick, to help with in these situations, for sure. Yeah. People who don't know, Rick is an expert in spiritual care, and some of these things come down to that sense of helplessness, and how do you engage with suffering when you can't make it better? Yeah.
I think we just have time for one more comment. I see Aaron Doss's hand is up.
Yeah, I was just thinking, Moira, as you were sharing that, and I know there's a wide variety of people on the call today, so not everyone is necessarily working in these emergency settings, but for those of our colleagues that do, or could eventually in the future find themselves in these situations, this whole concept of breaking bad news and communicating, in a textbook, it's quite clear and straightforward. I wonder if we as a group need to consider some sort of breaking bad news protocol when you don't have the half an hour that we would prefer to have with the family, or when you don't necessarily have a lot of insight of what the next hour or day is going to look like. And I think that and then practicing it. I know a lot of times within our palliative care trainings, when we're doing stuff online and in person, we try to do some sort of role play. I wonder if that would give some of our colleagues that are faced with these situations all the time some confidence and safety to actually just say the word. I don't know what's going to happen. I feel like your family member is about to die. This is what I'd like to talk about today. Or I don't know, even just saying the words. I wonder if
it's interesting.
That is something we could do to support our colleagues that are faced with these situations all the time. And just being that, in role plays, we take on the role of, it's an empathetic and compassionate way to teach people. I don't know if you guys ever practice quick breaking bad news is probably not the proper terms, but
I think that's a very good point. There's some skill issues in there, Aaron, but I think there's the other issue is how I handle my emotions. And I heard a lot of my colleagues saying, I just bottle them all up and try even harder to save everybody I come up against. So there's a bit of the skill, but there's a bit of actually the emotional content of that, which both needs addressing, I think, or needs supporting, not addressing, supporting. Yeah.
Yeah, I assume for most of our colleagues, giving a prognosis is ethical in and of itself, like you're saying.
I think it's ethics of that. I think, and I saw some really good communication happening. It's a natural response we have, that we want to make things better and we want to save people. And colleagues who've come in from trainings which are predominantly, say, trauma surgery, that that's what they're there to do. And the more holistic way of stepping back or handling responses is I think really important to explore and support and not judge.
Yeah, definitely. And I don't think that even is just in that very acute emergency phase. I do all the consults for all the MSF telemedicine, and there is very, very limited access to all the treatments we've talked about today. There is essentially, no cancer treatment, no dialysis. often no pediatric surgery in these settings that are very remote and very difficult to access. And yeah, a lot of what I do is support people's distress at the fact that they know there's something available, but they can't access it for a child, and help them in a way channel that desire to care for the patient into the things that we can do to care for the patient wherever they are, right? In that setting where there isn't chemotherapy. Like, it's very hard to look at a child who has a very curable cancer, for a physician who's been trained in a setting where that cancer, is essentially like 95% curable, to see that child and think, if they were somewhere else, I could cure them. And they get a lot of distress actually from those. And so a lot of what we do is, it's fundamentally very unjust, but where we are, we work through that and say, here's what we're going to do for this child, given that we can't transfer them.